we'll understand what edema and effusions are, why they occur, what are the types, and some examples for each type. Imagine that this is a blood vessel. These are the endothelial cells. These are the cells in the tissue. And this is the interstitial space. Under normal circumstances, fluid is constantly going out of the capillaries and coming back in. Hydrostatic pressure pushes the fluid out. Plasma oncotic pressure, mainly due to albumin, pulls fluid back in. Excess fluid is drained by the lymphatics and returned via thoracic duct. If this balance is maintained, tissues will stay dry. If not, edema can occur. Accumulation of excess fluid in tissues is called edema. If the same mechanism happens in a body cavity, it's called effusion. Same mechanism, different location. You can imagine a hydra with tentacles to remember that hydrostatic pressure pushes the fluid out. And imagine albumin like an O pulling fluid inside. Oncotic pressure pulls fluid inside. Now we'll look at the major causes of edema. Edema occurs when the balance between hydrostatic pressure and oncotic pressure is disturbed. Either the hydrostatic pressure increases, or the oncotic pressure decreases, or the draining lymphatic vessel is blocked, or the kidneys retain salt and water. Increased hydrostatic pressure is the most common cause of edema. It is usually due to impaired venous return. And if this impairment is systemic, it causes generalized edema. If localized, local edema occurs. A classical example is congestive heart failure. In this condition, where the heart fails, blood from the veins gets pooled in the peripheral areas, especially in the lower limb, mainly due to gravity. This increases the hydrostatic pressure, because of which fluid leaks out into the tissues. This classically causes pitting pedal edema. Heart failure causes bilateral pitting pedal edema because of increased hydrostatic pressure. Constrictive pericarditis can also cause bilateral pedal edema through similar mechanisms. Now, if venous obstruction occurs due to some local cause, say a tumor pressing onto the vein or lymphadenopathy or something like that, again, edema of that area can occur through increased hydrostatic pressure. Albumin is the most abundant plasma protein, and albumin contributes to most of the oncotic pressure. If albumin is reduced in blood, oncotic pressure reduces, and if oncotic pressure reduces, fluid can leak out of the blood vessels. So all those conditions where albumin is reduced in the blood can lead to edema, like reduced production of albumin from the liver, decreased intake of albumin like in malnutrition, or increased loss of albumin through the kidney in conditions like nephrotic syndrome, can all lead to reduced oncotic pressure and edema. This fluid leakage reduces the plasma volume, which in turn activates the renin-angiotensin-aldosterone system, because of which salt and water retention occurs in the kidney. This increases the intravascular volume, which in turn causes dilution of albumin So, oncotic pressure is further reduced. Also, increased intravascular volume causes increased hydrostatic pressure. So, because of these two factors, edema worsens. Kidney tries to help but ends up making edema worse. This vicious cycle of salt and water retention can occur in renal failure and cardiac failures and can worsen edema in both conditions. Lymphatics clear excess interstitial fluid. Obstruction leads to lymphedema. Even if hydrostatic pressure and oncotic pressure and renal function and all are normal, obstruction of a local lymphatic can cause edema of that region. It is seen in filariasis where the dead worm can obstruct the lymphatics and cause serious edema of the affected regions. This edema occurring in filariasis is called elephantiasis because of the sheer size of the affected region. Another classical example is upper limb edema, which occurs after radical mastectomy, where the axillary lymph nodes are also removed. Edema due to lymphatic obstruction is typically non-pitting. So pressure pushes out, albumin pulls in, lymphatics drain, and kidneys control blood volume. Another cause of edema is inflammation. Here, the space between endothelial cells is increased due to endothelial activation. This promotes exit of albumin and other proteins into the tissues. This fluid is protein rich, while all other edema which we studied is protein poor. This protein rich fluid is called exudate, while the protein poor clear fluid is called transudate. Inflammation produces cloudy, protein rich exudate, while increased hydrostatic pressure, decreased oncotic pressure, or retention of sodium and water, or obstruction of lymphatics, all of these cause protein poor transudate. Now we look at morphology of edema. Cardiac edema usually occurs in the lower limbs and it is due to gravity. So this gravity dependent edema is called dependent edema and is usually pitting. Means if you press it will form a small pit, and most of this edema is subcutaneous. So cardiac edema usually causes subcutaneous pitting edema. In contrast, renal edema is most pronounced around the eye or the periorbital region. So it's called periorbital edema. Pulmonary edema causes heavy lungs with frothy fluid due to mixture of air. Since brain is inside the skull which cannot change in its size, brain edema causes narrowed sulci and flattened gyri, and there is a risk of herniation of the brain in brain edema. Edema may be harmless or fatal depending upon the location. For example, pedal edema may be just annoying, while pulmonary edema can cause hypoxia and cerebral edema can cause brain herniation and death. As far as edema is concerned, always think of the mechanism behind it before answering. Next, we'll look at hyperemia and congestion. Think at the cell level.